Welcome to the Brain People Podcast, a show where four mental health experts team up to bring you practical tools for overcoming mental health challenges. The Brain People don't replace your doctor or therapist, but we will give you some extra tools to help you on your journey. So join us as we fight mental illness, one episode at a time.
Welcome to another episode on the Brain People Podcast. My name is Dr. Katie Cruz. I'm a licensed clinical psychologist, your host for today, and joined by my co-host,
Jonathan Edens. I'm a psychiatric physician associate.
Alrighty, and today we're going to take a deep dive into depression. And many of us may think that we know about depression, and I think it's probably because it's used quite often as a word to describe many different things, but we want to have a better understanding of what it is, especially by looking at different disorders within or under the umbrella of depression. And so we want to start with a disclaimer. Jonathan, you want to share that disclaimer with us?
Sure. So the content on this podcast is educational in nature. It is not meant to be used to diagnose or to treat any medical conditions or a mental health disorder. We recommend that every decision you make about your health be made by you in collaboration with your personal qualified medical practitioner.
And I'm glad we start with that because I know some people will be tempted to either diagnose themselves or someone they know. So I'm glad that that is something we start with. And then also it's important to think about when it comes to depression, but also with all disorders, that there's a kind of underlying thing, regardless of the disorder, of clinical impairment, significant impairment. Do you want to share about that, Jonathan?
Yeah. So before we mention that, most of what we'll be talking about today comes from, the DSM. We've mentioned the DSM many times in this podcast. I don't know if we've ever actually held up the book, but as you can see, it's a pretty thick book, and it just keeps getting thicker. So this is the latest 2022 edition.
And what does DSM stand for those who may not know?
The Diagnostic Statistical Manual. And so that's what we've been using, in psychiatry for decades at this point. We're currently, in sort of the Part 2 edition, what we call the TR of the DSM-5, which originally came out, I believe, in 2013. And so this newest edition just came out a couple of years ago. But the reason we say all of that is to say that in the DSM, there's specific diagnostic criteria for each one of these mental health conditions. And one of those criteria always is, does it cause significant functional impairment? So defining that is, a little bit nebulous and somewhat subjective, but basically it's does this series of or collection of symptoms, does it cause significant disruption in daily life? Does it affect things like self-care, home responsibilities, work, school, or relationships, right? And if it does, then it's going to cause a very negative impact on one's overall quality of life.
Yeah. And that's a key kind of element of it being a disorder, right? So that's why some people say, oh, I have depression, which rightfully so, they may have a depressed mood, but is it enough to warrant a disorder?
Yeah, sometimes, when I'm talking with a client and I'm trying to make a diagnosis and determine, what treatment options are best for them, really parsing out, okay, how much of an impairment is this causing you, or do you just tend to label yourself as being a depressed or anxious person, but in reality, it doesn't really change your day-to-day life all that much in terms of actual, functional impairment, right?
Yeah. So our listeners may have a disorder in the sense of significant impairment, but even if they don't, it's still good to don't turn off the episode quite yet. It's still helpful to understand the symptoms and, but ultimately, yes, there has to be an element of impairment for it to be a disorder. Okay, yeah, that's helpful, kind of foundational elements, foundational blocks. Why don't we just jump into the first one?
Let's do it.
Yeah.
So one thing we wanted to focus on is in this episode was the types of disorders described in the DSM-5 that are under the depression umbrella, but are not major depressive disorder. We have a couple episodes on that. If you'd like to listen to those episodes, it's episodes 40 and 41. We will be touching on it very briefly, just for the sake of being comprehensive. But it's really not going to be the focus of today's episode because there's a lot of other disorders that oftentimes patients hear about and they're like, oh, that actually makes a lot more sense. I tend to relate to those types of symptoms versus the MDD diagnosis, and that can often give you and your clinician or your psychotherapist a little bit more insight into, your day to day, and hopefully come up with better ways of treating what you're actually dealing with. So the first one I wanted to talk about is disruptive mood dysregulation disorder, also known as DMDD. Essentially, this diagnosis is primarily only used to diagnose adolescents. Specifically, we're talking about adolescents between the age of 6 and 18, and it's defined by having severe temper outbursts. And so this is usually in the form of verbal rages or physical aggression that are out of proportion to the situation and inconsistent with that child's developmental level. The mood outbursts are very persistent. Or I should say, excuse me, between the mood outbursts, the individual's personality, character, behavior is generally very persistently irritable, angry most of the day for nearly every day. And this, in order to meet criteria for the diagnosis, we generally put a frequency or time frame on that of being at least 3 or more times per week where they're having these severe temper outbursts and at least occurring for 12 months or more in multiple environments. So as I said, typically diagnosed in children. The reason for this diagnosis, or I should say the reason why in 2013 they started including this in the DSM, was because there are a lot of concerns about not having an adequate label for kids with these symptoms. And so a lot of them were just getting diagnosed with bipolar disorder, which is inaccurate. And in some ways can be harmful because some clinicians, being maybe a little bit naive, might have started jumping to bipolar medications, which have a whole host of pros for those that have bipolar disorder, but definitely a lot of concerns, especially when you're using them in such a young population. So prevalence estimated to be about 2 to 5% of children and adolescents. I think it's fairly intuitive that it would be more common in boys than girls, and this is typically what we see. Any thoughts on anything said so far, Katie?
No, I know you're going to go here next. That was my biggest thought of so how do you differentiate between bipolar and this disorder, especially among children, because children already have maybe some emotional dysregulation, but then these things are more persistent.
Right. And this is difficult to distinguish, often even for experienced clinicians. We're not necessarily always there in the midst of the child's temper tantrum. We're not there at home. And so we typically need collateral information from parents, caregivers, whoever may be intimately involved in the child's life, maybe even school counselors or teachers or people that are around the child a good percentage of the time. And so to differentiate this, we have to come back to what is the definition of bipolar disorder. And we've done a couple episodes. I don't think one of them's been released yet, but you can go back to one of our earliest episodes on bipolar disorder to get an understanding of what distinguishes that. And really, in summary, it's just the presence of manic episodes. And so manic episodes can come with irritability in times, but there's also a whole host of other symptoms that are characteristic of mania that we don't necessarily see in those with DMDD. The DMDD, really the primary feature is that irritability and those frequent temper outbursts, whereas really I'd call that more of a secondary feature of manic episodes. So children with DMDD that don't have bipolar just don't experience those manic episodes. There's also a couple other conditions that are common, mental behavioral issues in children. This would be oppositional defiant disorder and attention deficit hyperactivity disorder. Oppositional defiant has more to do with what's in the name, sort of being oppositional, being defiant, but we generally don't see sort of the degree of anger, the outbursts, the rage that you see in DMDD. And then ADHD, there definitely can be, especially when not adequately controlled, there can be some irritability there. It's frustrating for anybody that can't really focus, but say wants to, and that can leave them, being more irritable in general. So in terms of treatment, being that this is an adolescent population, we really try to prioritize psychotherapy and parent management training for these individuals. for these children. It's just, it's really important to get them set up for success over the course of their lifetime by giving them tools, both them and their family tools to help manage those behaviors and really set them up for as best of sort of success in their current life and also their future years as much as we can. And then, in sort of a backup fashion, medications might be used in some situations when the issues are more extreme and can't necessarily be managed well with behavioral modification.
I could imagine that maybe parents watching or listening might think, maybe my child doesn't have this or my adolescent doesn't have this, but maybe my child's developing some things. Is there any way to prevent this disorder?
That's a great question. I'm not a pediatric psychiatrist, and so I don't have as much experience with dealing with this condition. And so my answer to that would be not particularly deep, but I think basic things. Being a relatively new parent that I'm constantly thinking of is setting up the environment, setting up your home, setting up your interactions with others. Right? If you are a person that expresses a lot of anger and does so in an unhealthy way, you really your kids definitely pick up on cues and they learn from you. And that's not to say if your kid is dealing with DMDD, that is always your fault. I'm not necessarily suggesting that because like with pretty much all psychiatric conditions, we do believe there to be a genetic component to this. But setting up a safe, healthy environment where your kid has lots of opportunities to be nurtured by especially more parental figures in their life, not just you, but other adults that know how to handle their emotions well, is a really great starting point.
Mm-hmm. Yeah, and I would just kind of echo what you just mentioned of emotion regulation is huge. It's at the core of many different disorders, but especially in this age group when there's so many hormonal changes. But if parents can learn, because most parents don't know for themselves either, how to help their children regulate their emotions. I don't know if you've heard of the book, The Whole Brain Child.
I have. I've read it actually.
Yeah, I think that one's excellent of helping parents to educate their children to how do you deal with those big emotions.
Sure. Another thing I'd say is as a parent, not just dealing with your emotional state that's unrelated to your child, but also the way in which you react to your child. And so sometimes for a lot of parents, they may need therapy as well in order to deal with how they react, how they respond to their child's emotional outbursts too, so that they're not feeding into the issue. And so, yes, there is that part, like I said, of parent management training, but sometimes parents are just going to need a lot more one-on-one time because they're, probably understandably very frustrated that their child is behaving in this particular way. And so they may need their own coping strategies to deal with this, to learn to be more accepting, even of, or I should say to just be accepting of the emotions that come along with having such a disruptive child potentially. And so that may be definitely something to consider as well.
Yeah. And I just say come in sooner rather than later. I think some parents might, just think, oh, this is teenage years. But I'm so glad that you're talking about this because one, it's not often talked about. And then two, for parents to be equipped to say, when do I actually need professional help?
Moving on, the next disorder we'll talk about just very briefly is major depressive disorder. So this is characterized by one or more major depressive episodes, which involved at least 2 weeks of a depressed mood or loss of interest in nearly all activities. There's other criteria, things like energy, sleep, suicidal ideation, feelings of guilt and hopelessness, and so on. So those are incorporated in the diagnostic criteria. That duration is really important. Oftentimes we have people come in and they'll talk about feeling depressed for an afternoon or for maybe a couple of days in a row. We're not going to qualify those as major depressive episodes. And so that is important as we sort of segue into the next disorder. And the next disorder is previously called dysthymia. Now it's called persistent depressive disorder. And so with this, there's two major things that distinguish it from major depressive disorder. The first is the duration. That's kind of the most important. And then the second would be the intensity of the symptoms themselves. And so the symptoms that one can experience with persistent depressive disorder, it's basically the same symptoms that you see with MDD. It's just generally speaking, there is, at least in the acute sense, in the immediate sense, there is less impairment because the symptoms are maybe more mild to moderate. However, that duration, in order to meet criteria, has to be 2 years or more in adults and 1 year or more in children. So what I often do in order to just bring this point home is, people with persistent depressive disorder, they're dealing with, those sort of chronic feelings of sadness, maybe hopelessness, loss of interest, loss of energy, loss of motivation, and so on and so forth. So much so that it may become just like who they feel they are, right? And kind of the classic example, in at least the classic example for me that I frequently reference is Eeyore from Winnie the Pooh, right? Eeyore is generally just kind of a humglum, like that's kind of part of his personality, a negative individual, if you will, a negative. What is he? A donkey, I think. And so somebody like that has been that way for as long as 2 years or more would probably meet criteria for persistent depressive disorder. And so it's not I'm not. It's not to downplay when comparing it to MDD by calling it less intense, because it's so persistent and so chronic. There's not really much relief, right? And many of these individuals, in a certain sense, may be suffering all the more because of just how day to day these symptoms are, right? And so it's definitely important, for them to get necessary treatment. Now, you can have both. And so this we sometimes refer to as double depression. And so this would be 2 years or more having typically mild to moderate symptoms of depression with kind of acute exacerbations of 2 weeks or more that sort of take your depression up to a much more severe state.
And just to clarify, both being MDD and PDD.
And then treatments are very similar to what we would use for MDD. We're going to be trying to, when possible, identify root causes. So this might be things like trauma, medical conditions, substance abuse, etc., which we'll talk about in a little bit more detail in a few minutes. Psychotherapy is going to be a major component, hopefully for everybody that's dealing with this. Antidepressants and or other sort of maybe natural compounds that can be used to help alleviate symptoms of depression. Definitely an option for a lot of people. Nutritional therapy is a good thing to look at. So this would be looking at certain, say, vitamins and minerals. In addition, looking at certain foods, right, that might be helpful for a person. Some people just need to clean up their diet, and that can reduce inflammation. That can improve all sorts of both mental and medical issues, which we also we've had at least one episode on nutrition, which I believe was our first or second episode. So if you're interested in that, feel free to go back and look at those things. And then also lifestyle changes is just really, that's going to be something you should probably look at for all of these conditions. What most of the listeners listening to this podcast will probably realize is that we do sort of hammer home very similar treatment options for most mental health conditions. And when it comes to the umbrella of lifestyle changes, we really like the Choose Life acronym, and we have a couple episodes that just recently came out. I believe it was episodes 75 and 76. That do go into more about those Choose Life principles.
Do you have a list of all the memorized episodes, Jonathan? No.
I do have a list, but not memorized by any means, no. So those would be the treatments, generally speaking, for something like dysthymia.
Okay, great.
Moving on to the next disorder, we're going to talk about premenstrual dysphoric disorder. So premenstrual dysphoric disorder, also known as PMDD, it's basically, in simple terms, a severe form of premenstrual syndrome, or PMS. So this often includes things like mood swings, irritability, depressed mood, anxiety, along with things like fatigue, changes in sleep and appetite, and then other physical symptoms such as headaches, joint pain, and difficulty concentrating. Women with PMDD often experience extreme sadness or anger that is generally considered to be sort of disproportionate to whatever sort of context they're currently in. These symptoms are usually occurring during what we call the luteal phase of the menstrual cycle, right? And so it is generally temporary, right? Maybe a few days to a week or so, but then there's this cyclical nature to it, right? That's typically in line with the monthly menstrual cycle. Any comments on that? Being the woman in the room, I'm sure you've worked with other women that have dealt with severe PMS, maybe been diagnosed with PMDD, and I know we'll get into treatments here in a second. But I am curious. Maybe we'll jump into that, Katie. I'm curious if you had a lady that came in with PMDD and you're looking at a psychotherapy approach. What are some approaches you might try to utilize for them?
So the first one would be psychoeducation. Like so much, and I just say this to like all my women patients actually, because we're not very educated with what's happening in our bodies when we're going, well, and this is another part of the miseducation, when we're going through our period. And it's like, no, it's the whole month. That's the cycle, right? It's knowing at each different phase. And if you think about the luteal phase, it's half, like where it may be shorter or longer for different women at different times, but it's a majority of, leading up to your period where you have significant hormonal changes in general. Then you add this component. And so it would be first kind of laying down the layer of education about just a woman's cycle in general, but then adding the extra layer of them understanding this is not just regular hormonal changes, this goes above and beyond. So I would say psychoeducation would be a huge part of a woman struggling with this. And on top of that, then kind of mapping onto that, what do you do in order to try to balance your hormones more? There's going to be an element of that. And that does include, similar to also hormones in general when it comes to mood disorders, is what food, what exercise, what other things can stabilize that, and what are things that I can do daily. But also, this is something I'm very passionate about, and it's an area I want to learn more about as well, is learning at what point do I do different exercises and do I eat different things in order to meet the needs that I have at that phase. And then especially for PMDD, because it's so interfering in your daily life, you want to be extra intentional about being mindful of your body and your needs at that time. And then, of course, when you're doing those things and you still maybe have some of those dysregulation in your emotions, learning about that and learning how to manage that. And especially in the relational component of that, this is where like DBT can be very helpful, of like interpersonal effectiveness skills and learning when to step away if you know that you're at a place where you're going to be highly irritable, frustrated, angry, and that can be very disruptive for your relationships as well.
So safe to say, using some cognitive behavioral therapy techniques, some interpersonal therapy. I know you mentioned dialectical behavioral therapy in there. Probably, some components of acceptance and mindfulness as well would likely be pretty helpful. So the psychoeducation component, yes, very important for just about every mental health disorder. But especially when individuals and we'll say women specifically when it comes to PMS and PMDD, because it starts so early, oftentimes it just becomes like, well, this is normal for me, right? Like is this not what every person feels? And partly, of course, not being a woman, I don't necessarily know per se, but I assume that there is a lot of stigma, around PMS and PMDD and the symptoms associated with that. So I would imagine probably a lot of women do feel relatively isolated. They might be married and just their husband doesn't really understand what they're going through, and so it's this monthly frustration that maybe they've given up on trying to have a conversation with their partner, about what they're going through. And so all of that to be said is that psychoeducation piece can really help somebody that is maybe not fully aware of how much of an impact this is playing on their life, and bringing that into conscious awareness so that they take managing it a little bit more seriously. So the result will be their life is better, right? As and emotionally, hopefully relationally, all of these things are improved. A couple other treatment considerations would be things from a lifestyle modification, would be things like reducing caffeine, alcohol, and sugar intake. Um, More important, sort of leading up to the luteal phase, right? More important, sort of around that time when you are experiencing a lot of those symptoms. And I realize, it can be easy to say fall on alcohol and high junk foods as a means of kind of coping with, say, the stress or the irritability, or just the physical symptoms because you feel terrible, right? And you want something to alleviate that. But I think we all intuitively know that those things tend to make the problem worse. Medications definitely at times do play a role. For emotional symptoms, SSRIs, this would be things like Lexapro, Zoloft, Prozac are commonly prescribed. Hormonal treatments such as birth control or hormone therapy can also be useful for some women, and so definitely something that to talk with your doctor about if you are interested in those things. There's also some supplements that do have some research behind them that I think are worth mentioning. This is a fairly long list, so I won't go into any of them in any detail, but things like calcium, magnesium, vitamin B6, inositol, an herb called Vitex agnus castus, omega-3, primrose oil, and vitamin D and zinc may also be helpful in managing symptoms. I've seen, some of the women in my life personally find a lot of benefit from the magnesium, particularly if there's a lot of, because magnesium is one of those supplements that seemingly can do so much. And so when you're dealing with muscle cramps, you're dealing with irritability, you're dealing with maybe some sleeplessness, you're dealing with some stress and anxiety, magnesium could maybe help in a lot of those different categories. So worth considering.
And I'll just add, I think there's so many great apps these days that help track and that helps with the awareness. And because sometimes it's easy with the busyness of life to lose track. And so
Yeah.
the apps are great, or logging your symptoms and when they start and getting to know yourself very well.
If you're regular and you have your menstrual cycle every single month, that basically gives you 12 times a year to where you can do a little bit of trial and error, right? You can try maybe a supplement, you can maybe try a medication for a couple months or something. And if you're logging, especially prior to and then after you try to incorporate something new, then hopefully you'll have a lot of confidence that what you're doing is either working or not working. And just because it's not working doesn't mean it's a failure. It just means you learn from that. Okay, I'm going to move on and I'm going to try maybe the next thing in line that could be helpful. So I think tracking is a huge thing, hugely important thing for women that are dealing with PMDD. I think it's really should be emphasized more with most mental health conditions to increase the client, the patient's own awareness of their condition, particularly between visits with their care providers, so that they're better able to convey, the information, the most accurate information that's going on, so that they and their treatment provider can collaborate and make the best decision for managing their care. So yeah, tracking definitely underutilized, but nowadays there are so many. And maybe this is part of the problem. There's so many apps now that you can do this with. You can also just do old school, piece of paper, or using a calendar or something along those lines to keep some details about symptoms and how they transpire over time. So moving on to the next depressive disorder. So this would be substance/medication induced depressive disorder. So just as the name sort of sounds, this occurs when a depressive episode is directly caused by the use or the withdrawal from a substance. So in order to differentiate this from MDD or dysthymia or PMDD, we're looking at timing, right? We're looking at association and correlation with an obvious substance that is present or being discontinued within that time frame. So this temporal relationship between the utilization of a particular substance, whether it be a drug or a medication, is key to making the diagnosis of the disorder. And partly why it's key is because if it is something that can be maybe let's just say it's a medication or it's a drug, and that is what is causing the depression, then we want to address the root cause first, right? We don't want to necessarily pile on more medications, or if you're trying to do this yourself, unhealthy coping mechanisms to try to manage it, when really we should just get to the root cause and fix that. So some of the most common causes, and these are not in any particular order. I also, when I mention a particular substance, we sometimes get a lot of hate for this, but cannabis is definitely one that can exacerbate and or cause a host of mental health disorders, and depression. It can definitely do so. The fatigue, the demotivation. These are common issues with those that are overusing cannabis. Alcohol is another big one. This is well known to be a central nervous system suppressant, and so it is common that people that are overusing alcohol, particularly in a chronic way, often are going to deal with depression. So illicit drugs, things like cocaine, amphetamines, opiates, these are all also associated with causing depression. And then medications, and so this is not an exhaustive list, but it is longer. So many of these will not be necessarily relevant to you, but it is something to be aware of, because it might be a conversation that you're like, oh, I was not aware that this medication had an increased risk or was known to cause depression in some people. And so if you're somebody that maybe you started taking a medication and all of a sudden you started dealing with depression and didn't think to point back to that particular medication, it might be worth having a conversation with your care provider. So medications like corticosteroids, these are not necessarily just known for causing depression. They're also known for causing mania. That's an issue I've seen in many situations. Benzodiazepines, so these are anti-anxiety medications like Xanax, Ativan, Klonopin, Valium. These are also central nervous system depressants like alcohol, and so can cause depression while you're taking it. Can also cause depression when you're withdrawing from it, because the symptoms, the side effects can be very severe. Antihypertensive medications, now not all of them, but some of them more likely than others. The primary sort of two would be the beta blockers. So this would be medications like propranolol, atenolol, metoprolol, and another antihypertensive called clonidine. So the unfortunate reality is that I've just mentioned a few different classes of medications that are often used in psychiatry. Particularly, I have a particular affinity for the beta blockers, particularly propranolol and atenolol, due to their utility in anxiety, but we have to be careful and weigh the risks. Is it going to exacerbate your depression? How much can we get away with before it creates a problem, and so on and so forth. Birth control pills, we mentioned just previously, often useful for women dealing with PMDD, but also certain birth control pills that have the higher progestin content are known to be more strongly associated with inducing depression. HRT also, so that would be hormone replacement therapy, has that association as well. Chantix, so this is a smoking cessation agent, specifically for tobacco products. Chantix can be very effective for a lot of people, but especially those that are prone to depression, it's something that you should definitely be aware of. There are certain antibiotics like ciprofloxacin and levofloxacin that have an increased risk. And then antidepressants, actually, in some cases, right, there are a minority of individuals where certain antidepressants will actually make their depression worse. We know, or I should say, the FDA has put a black label warning on adolescents taking antidepressants, particularly due to that increased risk of suicidal ideation in the first few weeks of them taking the medication. So it's not just that population. We're often maybe a little bit more concerned about that population when it comes to suicidal ideation, especially so early on, for I think obvious reasons. But that being said, is that antidepressants generally have one or two different mechanisms, right? Most of the antidepressants that we use are SSRIs. There are some theories as to why certain people respond really well to antidepressants and certain people don't. One of those theories has to do with a process called methylation, which maybe we'll have another episode on that in
Yeah,
particular.
that'd be good.
But the idea is that if you are more if it can be determined that you're more undermethylated, then you're more likely to respond favorably to antidepressant medication. But if you're actually over-methylated, then oftentimes that's where we see patients either have a neutral response or a negative response when they try antidepressants. And so there are some options for individuals that maybe fall under that particular category, but it is something to be aware of. Treatment when it comes to substance medication-induced depressive disorder. I mean, the first thing, and I think hopefully the obvious thing, is are we able to reduce, discontinue, and/or substitute the offending substance for something else? Obviously, if it's an illegal substance, we don't just want to substitute it for another illegal substance. That's not necessarily the right approach. But in many individuals that are, say, having maybe an addiction to a certain illegal substance, there are prescription medications that may help to alleviate some of that chemical dependency, and that could be definitely useful in a lot of cases. Also, if warranted, detoxification and rehabilitation are definitely an option that we will sometimes use. Psychotherapy and lifestyle interventions. Feel like I'm sounding like a broken record, but pretty much always, if you can find a therapist and you can find a good one, especially like Katie here, then you're probably booked. So don't call Beautiful Minds and try asking. But if you can find a good therapist, that can definitely be a major asset to your overall treatment plan. And then the last thing would be augmentation with depression alleviating agents. Sometimes a person is taking a medication that is absolutely necessary. I'm thinking, certain cancer medications, certain antiviral medications, right? If that's what works for your system, other than this particular issue, then we will sometimes use an antidepressant agent in order to alleviate those symptoms while you have to be taking that other medication. So that's all I have to say about that particular. Yeah.
You emphasize therapy. I want to emphasize psychiatry in the sense of, like, a lot of my clients, I just recommend just go have an evaluation, because someone does need to be, having an overview of all these different medications that could be having that effect on depression, where they might be only identifying a certain event in their life that had contributed to it. And so it makes it harder for me in my job to not be managing all of that. And so I always tell people, it is, even if you don't continue to have like regular, medication refills or whatever it may be, still go see a psychiatrist, have an evaluation done, and make sure that these things are taken care of. And then the second thing I want to mention, both for psychiatry and psychotherapy, is be honest with your clinician, because there's so many individuals that are taking certain substances, or whether or not they mention or how much they're mentioning. Just be honest, because these things could be influencing your depression.
Yeah, and if you're going to a provider and you try to open up with them about maybe substance use, and you just get defensiveness, you get you feel like they're attacking or judging you for your use, that's probably not going to be a fruitful relationship, and so it might be worthwhile to look elsewhere. Generally speaking, I personally, I really try to do my best to empathize as much as I can, because I recognize that, had I walked in that person's shoes, maybe I would end up where they are, right? And me placing judgment on them, they probably get enough of that. And so if I can create an environment in which honesty and trustworthiness is built upon, then I truly believe that that's in most cases going to bring about better results than me just sort of placing judgment over them regarding their decisions. And so, all that to be said, it is important, as Katie said, to be open. Even if you maybe are stuck with your provider for whatever reason, and say they don't have the best bedside manner when it comes to these particular topics, it's still really crucial that you're honest and you're upfront and you're open, because a lot of substances have these fairly intense interactions with psychotropic medication that in certain cases can be lethal. And so it's really, really, really important to make sure that you are being upfront and open about your use. The last mental health condition that falls under the depressive umbrella that we'll talk about today is depressive disorder due to another medical condition. So once again, these last couple have been kind of obvious as to what they are, but this one, basically, there are a myriad of other medical conditions that are known to increase the risk of depression. This would include neurological disorders, endocrine disorders, other chronic illnesses, and infectious diseases. Just going through that real quickly. With certain neurological conditions like Parkinson's, Alzheimer's, multiple sclerosis, and stroke are commonly associated with depression due to their impact on brain function. Certain endocrine disorders like hypothyroidism, so this would be low thyroid, Cushing's disease, and diabetes can all lead to depressive symptoms as well due to the hormonal imbalance and metabolic changes that are associated with that. Other chronic illnesses such as cancer, heart disease, chronic pain, conditions like fibromyalgia, chronic fatigue, right? These things can definitely play a physical toll and just create an intense emotional burden of living with that chronic condition. And then infectious diseases, HIV, AIDS, hepatitis, and Lyme disease can cause depressive symptoms either through direct effects of the infection or through the immune response that the body sort of builds up to said condition. Katie, before we close up, I wanted to get your opinion on one particular patient subtype. When it comes to chronic illnesses, particularly with pain, I know you've worked with a lot of patients that deal with chronic pain and have comorbid mental health conditions. I'm just curious if you had any insights on how to work with this particular population.
Yeah. So a lot of it, the first couple sessions is psychoeducation as well, of them getting to know their condition. What are all the different kind of physical symptoms and medical components to that? And then how does that interact with their mental health? And then with the mental health, so for example, chronic pain, and there's different offshoots, medical conditions from that, a lot of it has to do with pacing yourself, because what happens is you try to live life the way that you used to or in a way that you think is normal, and that actually exacerbates your depression, your fatigue, or other symptoms. And so pacing is a huge component of that. Sleep, that's a huge component as well. And so working both with, trying to get adequate sleep, but then the anxious thoughts that are often related to sleep, which we know is related to insomnia as well, but it's specifically just often a natural part of the disorder. Exercise, movement, and trying to have, because what we know is the exercise is both beneficial for the chronic pain component as well as the mood component. And then a lot of it is the CBT, the restructuring, the cognitive restructuring, trying to change your thoughts. And then acceptance. How do I accept this disorder, especially if it's a chronic disorder, that it's going to be a part of my life? And then that has a lot of different implications for how do I accept it and make it address the elements that affect my relationships. Do I talk with certain family members about my condition and how it might look like at family functions? Do I have to tell them, I have fibromyalgia, and what that means for me is I need to rest when I'm at your house? And so working with the different acceptance elements, whether with relationships, your work environment, however it's impacting you, accepting that this is the reality of my life, and how do I make sure that I'm living accordingly and not resisting it, which then could cause more suffering.
Yeah. I did want to make reference to a previous episode. So you mentioned sleep as being crucial. We do have an episode on insomnia. That is episode 14. We don't just talk about insomnia as a diagnosis, but also, if you're just dealing with any sort of sleep issue, some things that you can hopefully utilize to your benefit. The other thing I gathered from everything that you were saying, and thank you so much for that insight, is it sounds like for a lot of people, probably learning when and how to say no in order to determine what the appropriate pacing is likely a crucial skill that people need to develop, because we often, we'll maybe some people are not so good at saying no. They still want to live kind of in the past, and so they try to do more than they're really capable at this particular point in their life, like you suggested. But then probably a lot of people say no to the wrong things, right? So learning when to say yes versus when to say no, and learning how to prioritize the activities that are going to be more beneficial for you in the long term for your mental and physical well-being, versus only engaging in activities that are more kind of immediate gratification and so on and so forth. So I imagine that's a big part of the conversation and therapy as well.
Yeah, then I just wanted to share a quick example of like the importance of knowing that this is a disorder and making sure that you get evaluated. Is I had a patient, and I learned this, early on, that I was like, wow, just completely missed it as a clinician, and I didn't feel too bad because their provider also missed it. But it was just like this learning moment for myself of a patient who had depression, but we had gone through treatment. She was doing better. And then the depression returned, but had a different kind of just kind of flavor to it, just different presentation. And, I was working with her prescriber, trying to understand, okay, is it the medication? Does she need to change? What's going on? And just trying to, one thing after another, trying. And, both of us couldn't figure it out. And it was Parkinson's. And it was one of the symptoms of, for her, it manifested primarily with the depression first, that you have these strong waves, especially in the early morning. And I just remember that thinking like, Katie, remember this for the rest of your career, because sometimes we only have the narrow focus of something happening in your life, some sort of trauma or circumstance or medication. And it's like, no, there could be underlying medical conditions that even like Parkinson's that could develop later in life. And so it's important for people to have a more broad awareness of the different contributing factors, because unfortunately, because it took so long to catch, she was in distress for so long.
Well, thank you for sharing. Thank you for sharing, Katie. That's a great example that I think kind of puts a bow tie on this particular episode. For our listeners, we hope you got some value out of today's information. Thank you for giving us a listen today while you're in the car or at home doing whatever you're doing. If any of this information you do feel is relevant to you or a loved one, please consider sharing it with them. And if it's specifically relevant to you and may actually change the way you do things, as we said before, right? Make sure you're doing so in a safe way, hopefully with a qualified medical professional. And with that, we just want to once again thank you to all of our listeners, and until next time.
Thanks for listening. If you enjoyed today's episode, please like and subscribe. Your engagement will help us reach more people who need encouragement. To hear more episodes, learn about our other mental health resources, or support us financially, visit thebrainpeoplepodcast.com.